Morning. As Carla said, my name is Angela, and I'm the Chief Perfusionist for Trinity Health of New England for St. Francis Hospital and St. Mary's Hospital. There's three of us presenting this topic today. With me, I have our Chief of Cardiothoracic Surgery, Dr. Gallagher, and wife of our patient, Robbie Walker, Susan Walker. Helps if I turn this on. So we have no disclosures or special interests. A little bit about us. I don't know how many of you are from New England. We are a 617-bed level 1 trauma center in Hartford, Connecticut. We have a cardiac case volume of about 500 cases a year, and we do somewhere between 30 and 40 ECMOs. We have 5 to 6 bed ECMO capacity, and to date, since the COVID pandemic, we've taken care of 28 COVID ECMO patients. Today we have a story about one of our COVID ECMO patients, and you're going to hear a story about how his family went to extremes to find him the help that he needed, and how in an uncanny kind of set of events, two groups of people got together that were miles and miles apart, and then what life is like in the aftermath of COVID. Before I go any further, I want to ask you guys a question. Anyone check in with their social media before you got here this morning? Snapchat, TikTok, no one. Facebook, Discord, my kids love this. Instagram, and recently acquired by Elon Musk, Twitter. Probably more people than care to admit, but I think we all spend a lot of time on our social media, which is kind of important for the story, but I'll get back to that. Let's talk a little bit about how we make medical decisions. Do we rely on hunches and opinions? We don't. We look for scientific evidence. We want proof. We want to see what the studies are showing, what the data is showing, right? That's kind of how we move forward. So let me ask you this question. How many of you would think this is an ECMO candidate? COVID positive? Okay. Unvaccinated? No significant past medical history? Single organ failure? Now what if I told you he was 52 years old? Intubated for 14 days? Pretty much everyone in this room would say no. Because back in the summer 2021, this patient would have a really hard time finding somebody to accept him for ECMO. There was a lot of COVID patients in the South. The hospitals were full. Everybody was at capacity. If you weren't at capacity, you were being really selective. Some of the other considerations: was this patient a transplant candidate? Because big transplant centers, how many beds did you have? Did you want somebody who was going to be there that was not a transplant candidate? Most likely back then you didn't. Because Elsa was telling us the best outcomes for our COVID ECMO patients were some of these criteria: a BMI of less than 30, less than 50 years old, although some centers were making the cutoff at 45. Intubation time less than 3 days. That was a big one. A lot of time people heard a week. Nah, no go. Single organ failure. Now what about vaccination status? Anybody consider vaccination status for COVID criteria? 98% of our patients back in 2021 were unvaccinated, with only a handful of patients that were partially vaccinated. So now you're all saying 52-year-old intubated 14 days, not doing it. Now what if you saw this?
Like you said, he's in ICU. He's been ventilated since the 25th of July. He is currently, he's on a ventilator. And he is in dire need of an ECMO treatment, which is not available at the hospital that he is in. And to transfer him to a hospital in Florida is next to him.
So I'm going to play you the audio. Apparently the audio video is not matching today.
Like you said, he's in ICU. He's been ventilated since the 25th of July. answered how she'd been in contact with a third party, an unverified team who sent supporting staff to take him to the center, to the hospital. At what point did you know he had to be admitted, and what was he saying?
I'm sorry you couldn't see the video, but that was the audio for the CNN interview that Susan did. Anybody change their minds about whether they want to take him for ECMO? No? All right, let's go back to Facebook. Anyone ever heard of Face Mash? Well, if you didn't, it's because in 2003 it was taken down after 2 days. Mark Zuckerberg started it as a prank website from Harvard University. He was a sophomore and he wanted to rank the attractiveness of his fellow classmates. It was otherwise known as Hot or Not. Well, the university didn't appreciate this. They thought he violated all kinds of copyrights and privacy laws, so they almost expelled him from school. Well, lucky for us, a year later he launched the Facebook platform, legally this time, by the way. I bet you that when he did this in 2004, from his college dorm room, that he would never expected that 17 years later that this platform would have the power to actually save somebody's life. Because on August 8th, 2021, Facebook and CNN helped bring the Walker family together with us in Hartford, Connecticut. This is Robbie Walker. He's a Florida native and a father of 6. On July 4th, he went to a family party. 5 days later, he tested positive for COVID. He was feeling not so well, fever, cough, weakness, so he had a telemedicine conference and he was given an inhaler and prednisone and told to go home and isolate. On July 15th, he was in the emergency room. He wanted a chest x-ray, but they said his lungs were clear and they didn't need to do an x-ray, so they sent him home. They said continue to isolate. 2 days later, he was back in the ED. Now they did the x-ray. He was still feeling bad, deteriorating. He was diagnosed with COVID pneumonia and admitted to the hospital. They started him on a course of remdesivir and Decadron, a high-flow nasal cannula. Unfortunately, he continued to deteriorate, and he was eventually moved to the ICU and placed on BiPAP. In the time that Robbie was with us, Susan and I had many conversations, and one of the things that she said to me that will always stay with me is that you leave the house with the TV on and the dog on the couch, but you know your life, it's never guaranteed. And I bet you in their wildest nightmares, the Walker family never imagined what would happen to them in the weeks and months to follow. Because on July 25th, Robbie Walker was intubated. He called his family. He was thinking maybe he was saying goodbye. He didn't know if he was ever going to see them again. Over the next week, the hospital that they were in said that the idea was to perform a tracheostomy and then move him to a long-term care facility who would wean him, eventually take him off the vent. But unfortunately, a couple days later, the hospital changed their minds. They told the family that his lung damage was irreversible. He would not survive the wait for a lung transplant, that he was not an ECMO candidate, and he was very likely going to die. Well, Susan heard the word ECMO. Well, what is ECMO? What is that? Is that something that can help? So her and her family, they formed a call center, and they called dozens of hospitals across Florida and up and down the eastern seaboard. But every time they were told, no, he's not a candidate. No, he's been intubated too long. No, he's not even a transplant candidate. So, out of an act of almost desperation, on August 8th in the morning, she did a CNN interview. Later that morning, I was getting ready for a Sunday, and it was nice up in Connecticut, good day for a hike, and I get this text from Dr. Gallagher. What about this family? And a link to the CNN interview. So I look at it, and I said, A few weeks earlier, we had had a bad experience with trying to transfer a patient from Florida for ECMO. We waited 5 days for insurance authorization. Literally, the team was on the tarmac waiting to take off to go get him, and he went into cardiac arrest. He was 45 years old and the father of 2. So I'm looking at this and I'm going, I hope that turns out better than the last one. How do I find his family? We didn't call them. They didn't call us. We saw them on TV. The CNN interview, it was very compelling, but there was no information, no way to contact anyone. So what do? Well, I went to my friend Google, and I Googled CNN, and I found a hotline number, and I called it, and I left a message, and I'm still waiting for them to call me back. So I said, okay, what about email? I found an email address, and I left an email message. By the way, still waiting for that one. Have not heard back from anyone. Maybe one day. Dr. Gallagher actually went back on Facebook trying to find Susan Walker, about how many Susan Walkers are probably out there. So he tried to send a message, but after a couple of hours, I was just getting frustrated. I don't even know if I can get anywhere with this. I have a perfusionist friend down in Florida, and I called her. I said, Erin, you got to help me. I don't know how to find this family. So she said, hold on, I'll get back to you. So a couple hours later, Erin got lucky. After many misses, she finally got a hit. She connected with Robbie's daughter, Molly, and she told her that although she was in Florida, there was a doctor up in Connecticut that was willing to help, that she just needed a number or a name of someone to talk to, and this is how I got Susan's cell phone number. So I said to Erin, I said, will she even talk to me? She said, yeah, she's waiting for you to call. Go ahead and call her. Later that afternoon, I finally called Susan. Now, what would your reaction be if you appeared on TV and a stranger calls you out of the blue and says, I have the treatment that you're looking for? Is this for real? Well, yeah. I tried to reassure her that I was not a crazy person and this was not a hoax and that we were willing to help. We just needed some more information. This is what we knew about Robbie Walker that day. We knew that he was a 52-year-old male with no significant past medical history. He had a BSA of 2.2 and a BMI 28. He had bilateral COVID pneumonia on the chest x-ray, although we had not seen one. They could not do a CT scan because they felt he was too unstable to transport to CT, so they didn't have one for us. He was on ROC, on and off Levo, Versed, and fentanyl. He had completed a 10-day course of Decadron and remdesivir. He had sub-Q emphysema since July 26 and no history of cardiac arrest. His vital signs were stable with normal sinus rhythm in the 80s and acceptable blood pressure and a slightly elevated temperature. His blood cultures were negative. His ventilator was pushing its limits. His peak inspiratory pressures were in the 30s, plateaus in the 20s. He was getting decent tidal volumes at 5 cc's per kilo or so, but they messed around with his IE ratio to try to ventilate him. He was having a progressive respiratory acidosis with hypoxemia, and they told us this was just getting worse over the past several days. They did have Flolan in use, and continuously, they did try prone ventilation, but they said he didn't tolerate it, was unsuccessful, and actually made the blood gases worse. Looking at his labs, there was nothing really that stood out to us. So Dr. Gallagher made the decision to accept him. We only had one patient on ECMO at the time, so we had some room. Now, I told Susan I could not guarantee her an outcome because I didn't know what the outcome was going to be. COVID was very unpredictable. We had 30-year-olds that didn't do so well, and we had 50-year-olds that did very well. We had patients that were on for a couple weeks, and then patients that were on, at that time, 90 days was our longest successful COVID ECMO, so it could have been months. I mean, since then, we've surpassed that at 131 days for a successful COVID ECMO, but back then, who knew? So I told her it was unpredictable and that the road's gonna be long. And I knew from past experiences trying to transfer long-distance ECMO patients that there's gonna be many hurdles. Transport, in-hospital, rehab, many things. She said to me, I have to try. If it was your husband, would you try? Of course I would. So what do we do then? What were our next steps? We had to get him from South Florida to New England. Well, the team that we normally contract with, and we had to contract because we're limited by distance, our mobile ECMO team could only go maybe a little bit outside of Connecticut, but not very far. So we contract. And the team we normally use, they were unavailable. So who to use now? This is where Susan did a lot of the legwork for me. We spent hours on the phone trying to figure this out. We wound up with innovative ECMO concepts. By the way, a shout out to Alex and his team. Very, very good job. Thank you, guys. This was our biggest hurdle, insurance authorization. If anybody's ever dealt with insurance companies for ECMO transports, now if you're a big transplant center, you probably just get the call, go out and get them, it's easy. But if you're contracting this out, you need insurance authorization for discharge, for acceptance at your hospital. But the biggest gorilla in the room is for transport. These are not everyday transports, and they need something called a single case agreement to do this, and it takes days to get authorization for this. So we were on the phone countless times, and I think insurance company called us at St. Francis 3 or 4 times over those 2 days. But we finally got it done, and maybe Susan is gonna wanna share later how we finally got it done, but we did. Now what about cannulation? We couldn't very well send Dr. Gallagher down there because Florida is a little squirrely about who they give privileges to for cannulation. You have to be medically licensed in the state of Florida. You have to be credentialed. You have to have hospital privileges, rules, guidelines, details. So we had to find a local physician willing to do this. And once again, between Susan and my friend Erin, we were able to get somebody to cannulate Robbie so that we can bring him up to us for ECMO. 3 days after Susan and I made contact, which wasn't so bad, Robbie finally got to us up in Connecticut, and a day later, she arrived right behind him. Now, she'd been driving for 1,300 miles, 2 days, and a pickup truck through New York City. So I'm from New York City, and this is really, really brave, and no small feat. But she got to us, and he was critically ill, and she was out of state in a place that she's never been before, and there was no guarantee that any of this would even work. What have I done? Was kind of her reaction. Well, what she did was, she never gave up, and the family never gave up, and they found him the help that he needed, a place willing to accept him. Let's talk a little bit about what we did, because now it was our turn. We got him here, so what do? We used the 2nd generation Centromag as our ECMO platform. We had the Seacrest blender, we used the Quadrox oxygenator, the Cincinnati Sub-Zero Blind Control 3 for a heater cooler. He was cannulated in the right IJ with a 21 French Biomedicus and the right femoral vein with a 25 French Biomedicus. Now this they had done in Florida. We recannulated him 2 weeks later with a Medtronic Crescent for mobility and physical therapy. They had given him 13,000 units of heparin bolus during cannulation, and we continued the infusion until we ran into a problem with bleeding from his tracheostomy, where we stopped it for about 10 days. Our PTT goal was 40 to 60, and then when we restarted, we actually restarted bivalve. Maybe Dr. Gallagher will touch on why we did that. We only had one oxygenator change out during that whole time. 22 days is how long he was on ECMO, which for us wasn't very long at that time. I mean, I was expecting a lot longer. This is a very first look at his chest x-ray. Now, we had not seen one yet, so we didn't know what to expect. I remember looking at this with Dr. Gallagher, and we're looking at each other going, that's not so bad. I mean, we've seen a lot worse for our COVID ECMO patients. And he's gonna talk later about his chest x-ray progression, but we were going, okay. I know some of you in the back probably can't see this, so I'm gonna do a quick run through our ECMO run. Now, we were on full ECMO support for about 6 days. We had a flow of about 4 to 4.5 liters per minute with FiO2 and 100% and a sweep between 3 and 4. Now, after about 6 days, his PO2s were over 100 and his CO2s were stable, so we decided let's try to wean. We didn't know how long it was gonna take, but let's give it a shot. We performed the tracheostomy about 5 days into it, and the next day started a slow wean. We were able to quickly wean his FiO2, but the sweep We took our time with that because in our experience, the COVID patients took a while for their lungs to be able to pick up that CO2 clearance. So we didn't want to push it. We took our time. We ran into problems with bleeding from the tracheostomy. We had to go back up on ECMO support. He needed a transfusion, a re-exploration. It took us about a week to figure that out. And this was not uncommon for our COVID ECMO patients. A lot of them bled from everywhere, chest tubes, trachs, wherever. So this was not unexpected, and I didn't warn Susan that we may have some complications. When we finally got that under control, we were able to start a wean again. But we still, once again, we took it slow. We wanted to make sure we had gone this far, they've come this far, that this was actually gonna work. Once again, we were able to wean him down to half a liter and 21%. And right before Labor Day, we decannulated. Now, a few days before that, he had been on pressure control ventilation on the vent, and we had switched him to CPAP, and he did very well. Eventually, he progressed to 40% trach mask. And that's where he went to the step-down unit, and that's where he went to rehab.
Do you have anything to say to your
No
wife?
audio.
Say it. Say it. Don't
I think for
stop
the
it.
next section, we'll try to. So, I don't know if you can read his lips, but when he can talk, she took a
All
video
right,
and
we're
he
gonna
says,
take
I
a break
love
for
you.
today, okay? Good job.
On September 14th, Robbie was discharged from our facility
Do you have
to a
anything to
rehab
say to your
facility,
wife?
like I said, on 40% treatment.
Say it. Say it.
39
Don't
days
stop
after
it.
that, he went home with no O2 requirement at all. He was a little hesitant about leaving us. He didn't want to go,
All right, we're gonna
but we
take a
said
break for
it's
today,
time for Birdie
okay?
to fly.
Good job.
I'm going to turn this next one over to Dr. Gallagher.
Good morning. When Robbie got to us, we took obviously basic labs, and there wasn't anything particularly remarkable. His hematocrit was a little low, probably because he had just been cannulated and transported to us. He never really had much of an issue with regard to that, other than the time when he bled from his tracheostomy. The rest of his labs really were not that remarkable, and I think that was one of the things that makes a difference in the recovery of these patients, is that they don't go on to develop multi-organ system failure. His creatinine was about 1.5. It never got much above that, dropped down to fairly normal levels. His lactic acid was never elevated. He never had liver dysfunction. He did develop positive sputum cultures with gram-positive rods and gram-positive cocci, and he was treated for that, but it never really evolved into a full-blown pneumonia, and his liver functions were pretty normal. His echo really was unremarkable. He had good right and left ventricular function, no evidence of any kind of valvular abnormalities. And this is, I'm sure, really hard for you to see, so I'll sort of go through it. But basically, when he got to us after cannulation, he had reasonably good tidal volumes on relatively acceptable pressures. So his inspiratory pressure started out at around 20 with a PEEP of 10. Respiratory rate was 14 and an FiO2 of 60%. His peak pressure was 31, and his plateau was about 34. So a little bit on the high side, but still not bad. And I think the striking thing with these numbers really is the tidal volumes that he was able to generate at those inspiratory pressure volumes. And I think this speaks to the fact that his compliance was relatively good, even though his ability to exchange gases was not. And then he went on, as you can see through the course of his events. We switched him out to a crescent cannula after about 2 weeks with his standard cannulation with femoral venous drainage, and returned to the right IJ. The idea was that it makes him more mobile, and as he began to wake up and interact more, we thought we'd be able to mobilize him more. But he wasn't really on ECMO much for about a week after that. So he, in terms of the benefit from the switch out to the Crescent, maybe not, not as optimal as it might have been, but ultimately his course progressed quite quickly, and he was able to be decannulated. And as Angela mentioned, the chest X-ray when we first saw it was not nearly as bad as some of the ECMO patients, the COVID-related ECMO patients that we had. So we were impressed by the fact that he didn't have a complete whiteout of his lungs, and as you can see through this series of X-rays, he never really got any worse. He never developed overlying pneumonia on top of his underlying ARDS from COVID, and I think that goes along with the with the tidal volumes that he was able to achieve and the compliance that he demonstrated. Unfortunately, I don't have the actual CT scan to show you, but if you look at the bottom of this report, it says there was virtually complete opacification of the dependent portions of both lungs. And I think that's something that we see so often in these patients. And it's so disheartening to see in some of our COVID patients that they go on to develop complete opacification, and then they develop necrotic areas in their lungs and pneumatoceles. And you can see these develop. The lungs are whited out, and these kind of areas that are clearly, and they look like maybe the lung is starting to recover, but really what it is there's air that's trapped in a necrotic section of the lung, and that's just going to predispose the patient probably to a pneumothorax or other complications. He later underwent a cardiac catheterization during the course of his hospitalization for a rapid atrial rhythm and some ST segment changes, but his coronaries were normal. He really had a very stable, progressive course throughout his time with us, and we wish that most of our patients who went on ECMO progressed the way Robbie did throughout his course, so we were quite pleased. And the time on ECMO was relatively short compared to some of our other runs. He did have a small sacral pressure ulcer that developed, and then some pressure along the right ear where we had to secure his his cannula. The main complication, as Angela had mentioned, was the bleeding from the tracheostomy site that required ultimately removal of the trach, reintubation, and the packing of the tracheostomy site, and then ultimately going back to revise it and control whatever was bleeding, and then reinsert the trach. So that was really the main setback that he experienced, and probably his time on ECMO would have even been shorter had that not occurred. So what have we learned in treating COVID patients on ECMO? I think we've learned a lot, and I think there's a lot more to learn in general with COVID-related ARDS and ECMO in general. But with regard to COVID-related ARDS, who survives and who doesn't, ECMO does an amazing job sustaining the life of a patient with ARDS. I mean, we've kept patients alive for months, but it's ultimately the host response to the inflammatory cascade that determines survival. So we've kept patients on ECMO with pristine numbers, and ultimately if the lungs don't come back, they're not transplant candidates, you're at an impasse, and it's a very, very difficult situation. And the treatment options are not great. I mean, none of these really work very well. Steroids, remdesivir, convalescent plasma, monoclonal antibodies, surfactant, diuretics, none of these help. We have noticed that patients, they do have a basement membrane capillary leak that goes on for weeks and weeks. So if they get a little positive with their fluid balance, the lungs, the next day, you see the lungs are starting to get white again. You try and dry them out, the kidneys start to take a hit. So it's really a balance. So fluid management is important, but it's certainly not going to be what allows the patient to recover. This is not a fluid overload situation. And antibiotics for overriding infections obviously are important, but they don't really have an impact on on the COVID-related portion of this. There have been demonstrated compliance phenotypes in early ARDS. Some of the patients demonstrated dissociation between the degree of hypoxemia and the compliance of their lungs, and I think that's what Robbie had demonstrated. And they've noted that those who retain their compliance or regain their compliance relatively quickly have an improved survival. Lung protective strategies have been described, and these include plateau pressures less than or equal to 25, a respiratory rate between 5 and 10, PEEP somewhere between 10 and 15, an inspiratory pressure less than 15, and an FiO2 of 50%. And these, I think, are helpful, but I think one of the things we learned with regard to quote-unquote resting the lungs is that if you rest the lungs the way we thought of resting the ventricle when people are put on left ventricular assist devices, you lose ground, because if you go too low, if the inspiratory pressures are too low, if the PEEP is too low, what you find is the patient's lungs de-recruit, and when they de-recruit, it's sometimes very difficult to get the lung re-expanded again. So we would drop the ventilator settings and the inspiratory pressure down to minimal levels, and when we'd come back the next day, we'd find that the tidal volume was almost completely gone, and the lungs look whited out on chest X-ray. So we found that there needs to be a happy medium. You want to avoid the barotrauma that's related to high inspiratory pressures and high PEEP, but you don't want to go so low that you lose alveolar ventilation. So in the course of treating some of these patients, and as Angela mentioned, we had a lot of bleeding complications, no matter what we did: percutaneous tracheostomies, open tracheostomies, chest tube insertions by very experienced PAs that put in hundreds of chest tubes. Patients bled on ECMO. Was it specific to COVID? Was it specific to, or was it just in general on ECMO? But there's this phenomenon of acquired von Willebrand syndrome. And virtually every patient on ECMO seems to develop this acquired von Willebrand. It leads to profound platelet dysfunction, and the incidence of bleeding complications increases significantly. As I mentioned, trachs, chest tubes. We had just putting in a feeding tube. We had so many patients that ended up with nasal bleeding and ended up with ENT consults and nasal packing for days or weeks. So it's really, really a serious problem. In this study, there were 59 patients on VV ECMO, and they did light transmission aggregometry of the platelets and flow cytometric quantification of platelet granule secretion. And what they found is that all patients developed severe acquired von Willebrand syndrome within hours of initiating ECMO. So there were 60% of the patients were noted to have abnormal numbers within 3 hours, 86% in a day, and by the second day, virtually everyone had it. So in other words, you have platelets, you can measure a platelet number, but none of those platelets are working. And so these patients are really, really at risk for bleeding complications. So you have this, this dilemma of we need to anticoagulate them. So on top of this profound platelet dysfunction, you're either heparinizing them or putting them on other anticoagulants to try and maintain them on ECMO. The etiology of the acquired von Willebrands is caused by shear stress inside the ECMO circuit or the MCS device. So we see this in ventricular assist device patients as well, not just ECMO patients. And it's characterized by loss of high molecular weight multimers of the von Willebrand factor and decreased collagen binding to the von Willebrand factor. So the treatment options are relatively limited. You can give von Willebrand factor and factor VIII concentrates. You can use antifibrinolytics. It doesn't really affect the platelets so much, but what it does is it affects the breakdown of the clot that you do form. GDAVP doesn't really work very well in this situation. There's only a 10% response rate in ECMO patients. And other options such as plasmapheresis or gamma globulin don't work in ECMO patients. It works in acquired von Willebrands for other etiologies, but not for patients on ECMO. So just in terms of this concept of out-of-the-box strategies, a couple other things, and Angela, if she has time, may want to touch on these. A couple of things we've done with patients when we were really at wit's end in terms of what to do when we couldn't oxygenate them was go to a dual oxygenator. So I had a second oxygenator in line, which got us to the point where we were at survivable PO2s, and to the point where we could sustain that patient, to the point where when they started to turn around, we could keep them, at a reasonable, PO2 and CO2 to keep them alive until they could recover. And then the second thing was adding a second venous cannula to drain the upper body. We had particularly one patient who we just couldn't get the flows. She had PO2s in the 40s. We had added nitric oxide to see if we could get, improved oxygenation through her lungs. And the idea was, if you think about what we do when we go on pump and we use bicable cannulas, and we're basically controlling all of the venous drainage, running it, as if we put cable tapes on and running it through the pump, and you can control all of the venous return. But in this situation, when we have a femoral venous cannula and we're returning through the IJ, we're not really draining the upper body. So we placed the subclavian cannula. We were able to get only a little bit over a liter from that, but it was enough to get us to a point where we could improve our flows and improve our oxygenation. And then as the patient started to improve, we were able to remove that cannula at a later point in time. So what have we learned? Well, we've learned to push the boundaries. We've learned to share our experiences at meetings such as this so we can really all learn and grow. We've learned that guidelines are just that, guidelines. They're not rules, they're guidelines, and that they're meant to be tested and pushed. And only those who risk going too far can possibly find out how far one can go. So now I'd like to invite Mrs. Walker up to give her thoughts on this experience that she and her husband went through.
This is Susan Walker, and you've heard enough about us, and now you're going to hear from her. But before we hear from her, the rehab facility that Robbie was in made this video after he was discharged, and we're going to try our best to get this going. Because I think if you don't have tissues, you may want to grab some. Play. Ready?
One second. Okay, 1 second. There you go. All the way back.
Okay.
Are you ready for it?
Yeah.
2, 3.
Hello, my name is Robert Walker. I'm here at Gaylord, and I'm here recovering from COVID. I was very active. I had my own business. We were either boating or doing things. We live on the water, so we were always a very active family. I had no underlying conditions or anything like that, so I had no reason to think that it would be anything.
Robbie contracted COVID in early July 2021, this past summer. We ended up at the ER for chest x-rays on the 17th, and he was admitted into the hospital with bilateral lung pneumonia. He ended up in ICU, and on the 25th he was intubated.
The last memory I have is calling my kids and my wife and telling them that I loved them. And to let them know that I hadn't signed to get intubated. So I was hoping that I wasn't saying goodbye.
We were told on August 4th that he was not going to survive COVID. From there, desperately seeking out our options, we searched out hospitals that could provide a greater care of treatment for him, which was ECMO. We say 169. It was probably over 169, but that's kind of the final count that we have. After we've been denied by every hospital that we've reached out to, my son-in-law happens to work for CNN. My daughter said, "Mom, go on CNN. Let's use that platform to tell them that we need ECMO." We did an interview, and it aired early that morning. Dr. Gallagher from St. Francis Hospital happened to see it around 2 o'clock that afternoon as he was just thumbing through social media. He reached out to his chief perfusionist. So Dr. Gallagher and Angela agreed to look at his records and see what he looked like as a patient, not as a formula. And thank God they did, because they agreed to take his case. So we went through the process of getting him transferred, and he was cannulated for ECMO in Florida and then airlifted by medical jet to Connecticut, where he then stayed at St. Francis Hospital for his ECMO treatment.
It saved my life totally. St. Francis took a chance on me as a person instead of a statistic, and then Gaylord is hopefully giving me my way of life back. And everything that I've done here so far has been great. The people are very caring, very attentive, very uplifting, but they push you. It feels that they genuinely care. I would definitely recommend Gaylord.
We knew that he was going to have to go into a rehabilitation, so we toured, and Gaylord was our top choice. Gaylord came highly recommended both by Dr. Gallagher and by Angela and the staff at St. Francis. It's almost like you have your own personal physical therapist and your own personal occupational therapist, because you're not just a number. You know, they take their time, they explain things to you, they work well with you, they care. There's a lot of compassion. The doctors stop by the room. Unfortunately, Robbie was not vaccinated. Neither one of us were. We had talked about it, but we were not vaccinated.
From what I understand, if you're vaccinated, you may get sick, but you're not going to be like this. Again, I understand everybody has a choice, and I don't want to tell people they have to get vaccinated. My suggestion is that you do get vaccinated.
My hope is that we return to life as usual, that we find our new normal, and Robbie has the patience and the strength just to get better, and we just live our life together. There's just so much that we need to be thankful for in the moment, and that's what we're going to do.
It's beyond miraculous. She's my hero. You know, she started this whole process, and then other people stepped in and helped with it.
Clicking. I'm clicking. Keep clicking.
Bottom right. There we go.
Good morning. It's a true honor and privilege to be here. I'm probably going to repeat a lot of what was just displayed in today's presentation, because I wrote my story without seeing everything come together. So I apologize. As Angela and Dr. Gallagher just mentioned, my husband was hospitalized and intubated in Central Florida Hospital for bilateral COVID lung pneumonia. Robbie was isolated for 2 weeks with only one 30-minute visit per day. As his days in isolation continued, panic and anxiety set in. He was fearful he would not make it out alive. When Robbie was first intubated on July 25th, he was told that by being intubated, it would give his body relief so he could heal. He was not intubated out of emergent necessity at the time. So he signed the papers and agreed to be intubated. He called me that morning, right before, and told me what he was going to do. I begged him not to, but by the time I got to the hospital, the procedure was already underway. The hospital was at full capacity, and doctors rounded before visiting hours, so it made communicating with them very difficult. I kept a journal from the very beginning, and I logged on to Robbie's medical portal multiple times a day and began learning what tests they were performing, why and when, how often, medicines he was receiving, his stats, what was good, what was bad. I had an ICU nurse friend in South Florida that would guide me in what they were doing in their facility for their COVID patients. Proning, ivermectin, daily ABGs, testing, and so on. I would Google other treatments and ask doctors about medicines they've not yet prescribed. And I was quickly becoming Robbie's advocate, his voice. As the 9 days went on, being intubated, Robbie stayed primarily stable. I was told multiple times by doctors and staff that the plan was to have Robbie trached by week's end and then transferred to a long-term acute care facility for weaning purposes. They suggested I become proactive and take steps to make sure that he had a place to go when the time was ready. So I did. But on day 11 of being intubated, I was told Robbie had irreversible lung damage and that he would not survive COVID. Just 2 days prior, he was stable, and I had visited and decided on an acute care facility in Gainesville, Florida, to send him for trach weaning. As you can imagine, instant devastation. I could only think to myself, how could this be? What was I missing? What were they missing? Outside of COVID, he was a 50-year-old man. As he laid there and for the past 19 days, he actually looked good. His skin color was good. He was urinating and defecating on his own. He was not on any diuretics, not having any signs of cardiac issues, no liver failure, no kidney issues. He had one failing organ, his lungs. So still confused by the news, I asked about a lung transplant. I was told he wouldn't survive the wait list and that he would need to qualify for a treatment called ECMO, and that unfortunately he didn't fit the criteria for ECMO. But furthermore, they didn't offer it. So I asked if we could transfer him to a facility that did offer ECMO. The chief intensivist that day told me he was too unstable to transport. I felt defeated. If you've ever lost someone you love, then you know how helpless it feels when someone you rely on tells you that they have exhausted all treatments for your survival and that the journey is over. It ends here. Well, not for us. At least not yet. I relocated to a hotel room close to the hospital Robbie was in from the time he was intubated, so that I had easy access to him, so if the ICU desk didn't answer the desk phone or a doctor didn't return my call in 8 hours, I would go to the hospital and get my answers. The morning after we were told to make other plans for Robbie, I woke up and decided to turn my hotel room into a makeshift call center. And families and friends gathered around, and we called over 160 hospitals in the state of Florida and surrounding the neighboring states once we exhausted all the hospitals in Florida that offered ECMO. We did find about a dozen beds, that would look at Robbie's case, but everyone denied him. I was told first it was because he was intubated too long, and second, it was his age. 14 days intubated and the stars started to align. As you heard, my son-in-law works for CNN, and he made a phone call to one of the writers asking if they would take our story. I offered up an interview of to why me and Robbie were not vaccinated, and we would speak out and encourage people to be vaccinated. When Robbie called me to tell me he was being intubated, he begged me to go and get vaccinated and told me how regretful he was of not leading our family that way. So the next day I did. I was vaccinated. I went on CNN on August 8th to explain why we were not vaccinated and to plead for a doctor to help my husband that was lying there helplessly. I guess I'm supposed to be clicking these pictures too. 2 p.m. that day, I was contacted through social media by a colleague of Angela's that there was a possibility of an available bed and treatment for ECMO. There was hope. Dr. Gallagher reviewed my husband's records and accepted him. 16 days intubated. If Dr. Gallagher and Angela would have seen him as a formula and not outside of the parameters that were against him, Robbie's life would have been over. Robbie joins me today in the back of the room, standing in the yellow shirt. Ecstatic over the news, I raced to the hospital for my visiting hour to make sure that hospital that Robbie was in was communicating with the hospital that Robbie was going to be transferred to, St. Francis Hospital in Hartford, Connecticut. As I entered the ICU wing with an attitude of celebration, I could instantly feel the tension toward me from the hospital's doctors and staff. I was immediately approached by the chief intensivist with frustration and discouragement of my fight to have my husband transferred and have him treated with ECMO. It was obvious she had already heard the news of my national interview, and she had also heard from Dr. Gallagher and Angela's willingness to try and give Robbie a chance. She continued to tell me he was most likely going to die in transit and that I really didn't want to do this. I really couldn't understand at the time why they too were not excited for us, and it still surprises me that they actually tried to talk me out of fighting for my husband. I personally couldn't just sit there and watch him slowly start to shut down. In my mind, why not give him a fighting chance and let him die trying than to not try at all? It took 3 additional days from that point to organize insurance for transfer, force ECMO cannulation at the hospital he was in so he could survive the flight, and arrange the medical air flight and medical air staff. Angela warned me on Sunday that the next 24 to 48 hours were going to take persistence. But little did I know my biggest fight and pushback would be from the hospital that he was in to help me get him cannulated so he could be flown to the hospital for his possible life-saving treatment. Their stance with me at the time was because they did not offer ECMO, they did not have a cardiac surgeon that was able to cannulate Robbie. Well, that led me into sitting at the bottom of the stairs of administration for hours until a hospital staff came down to talk to me about their hospital ethics and humanity. I wanted answers as to how they were going to help me get my husband cannulated instead of blocking Robbie from getting the help he has been offered and deserved. The administrator, the CEO, spent some time listening to me, and I was told that she understood our position and would make some contacts and see what they could do. In the meantime, and still desperate and no time to spare, I contacted a head doctor from another hospital who could not believe the fight that we were in. He agreed to cannulate Robbie and stabilize him in order to transfer him to the facility that has already accepted him. So I again raced back to the hospital in high hopes
that we could resolve this and suggested we bring in a doctor in from another hospital that was local. They took the position that the hospital board would not allow an outside doctor to come in and cannulate without state-approved emergency privileges for liability reasons. The outside doctor I had contacted was furious and even attempted a phone conference with me with the hospital's administration. He even went as far to tell them that we could discharge Robbie in ICU and that they would cannulate him bedside and transfer him to the airport to have him flown out to St. Francis, where Dr. Gallagher and Angela were eagerly awaiting him. I am an ordinary person, and this fight should not have been this hard. I was just a wife who didn't want her husband to die. I can only imagine how many other families out there lost loved ones because of a set criteria. I was fighting insurance to expedite transferring and arrange for medical flight approval, at the same time calling the meetings with CEO and higher staff officials at the hospital he was in because they did not have a house doctor that was willing to cannulate for ECMO, but nor would they allow a doctor to come in from the outside that was willing. We missed 2 insurance-approved flight opportunities during those 3 days because we couldn't get everything aligned. 17 days at Robbie's bedside, 4 p.m., a doctor from the hospital walked in and told me they found a doctor that would cannulate my husband if I could arrange for him to be transferred the next day. So with no time to spare, I couldn't rely on the insurance to approve the flight. I had already contacted and spoke to several transport companies when Angela and I first spoke. With no time to risk, I called Innovative ECMO Air Team, and within 60 minutes, he was scheduled for transport. The flight was $92,000 out of pocket. Robbie and I had just cashed in our IRAs, ironically, a week before he got sick. 18 days intubated, and by the grace of God, Robbie was cannulated for ECMO, transferred by ambulance to a local airport, and medically flown to St. Francis Hospital in Hartford, Connecticut to begin treatment. Despite the criteria odds of my husband receiving ECMO, Dr. Gallagher and Angela took a chance and saved Robbie's life. Robbie did not need a lung transplant after all and returned home 3 months after contracting COVID. His pulmonary function in December of last year was 46%, and today he has improved to 66%. He continues to improve every day. He is not on any oxygen and was weaned from prescribed metoprolol 2 weeks ago. He has been released from doctor's care and will return annually for checkups. He is not taking any medications at this time. We are forever grateful for the efforts of everyone involved to help save Robbie's life, but especially to Dr. Gallagher and Angela for thinking outside the box. Thank you. Thank you. Just finish this off. This is Robbie and I in our makeshift gym that we created in our garage. Us having a little fun after we got home. This was around Thanksgiving, having a family game night. Robbie and I love to airboat. We were able to take the airboat out for the first time last month and enjoy some Florida sunshine. I got my husband to spend Christmas with me again. And we just thank you from the bottom of our hearts.
Thank you so much for sharing that. That just makes all of us feel so good about what it is we do to see these amazing outcomes. What an inspiration, and what an awesome team that you are to be able to pull this off. So thank you. And you look amazing, Robbie. You look